Someone has said Munch. Yes. So as Simon told, I'm Philip Vestergaard Munch, a medical doctor and PhD student from the Department of Clinical Epidemiology in Aarhus. And the topic of my PhD is acute kidney injury in cancer patients. And beside of that, I'm also doing other studies relating to kidney disease in different patient groups. And I'm here as a part of my PhD in Denmark. It's mandatory to spend at least 1 month abroad in another country. So that's really cool. I've just added a short agenda for today. So I will start this presentation by giving a short introduction to the Danish healthcare system, and I'll talk a bit about the health of the Danes. Then I will move on and tell about the epidemiological kidney research that we do at our department. And I will also come with some examples from my own research, and I hope this will give you an impression of both the opportunities conducting research in Denmark, but also some of the challenges we often encounter. So let's start talking about the Danish healthcare system. So in Denmark, we are around 5.8 million inhabitants. That's quite similar to the population of Scotland, I think. And we got a universal healthcare system where most expenses or most services are free of charge, and these includes services provided at hospitals and in general practices. But there are also some exceptions. So the patients have to pay at least a part of the expenses when they go to the dentist, and they also have to pay a part of the expenses to drugs and psychotherapy. And yeah, here's a map of Denmark, and Aarhus is almost placed right in the middle of the country. Here I have included a graph showing how Denmark is performing according to the population health and the healthcare system. I thought it would be interesting to see how Denmark performs compared to other OECD countries. So the green dots represents indicators where we perform better than the average, whereas the red dots represent indicators where we perform worse than the average. And it's a bit hard for you to see, but for example, we can see that we have a quite low treatable mortality rate. We got a quite low diabetes prevalence. A lot of Danish women are following the mammography screening program. We tend to eat quite healthy. And Danes are typically or generally very satisfied with the Danish healthcare system, and also see that we are spending a lot of our GDP on the healthcare system. But there are also some red dots. And you can see these two red dots are very far from the average. And the red dot up here is heavy drinking. We have some very bad habits about heavy drinking in Denmark. And the red dot down here is the number of admissions with chronic obstructive pulmonary disease, and that tells you something about the smoking habits. So Danes tend to smoke a lot and drink a lot, and that also affects the life expectancy in Denmark. In Denmark, we like comparing ourselves to other Nordic countries, Sweden, Norway, and Finland, and we are the red line down here. And as you can see, compared to the other countries up here, we are still behind this country. Then we got a line down here. This is Greenland, and Greenland is actually also a part of the Danish realm. and they are also having some serious problems about drinking and suicide. I have also added some figures which gives you an idea about the problems of inequity in Denmark. So I'm sorry, these figures are in Danish, but they have just recently been published in the medias. So this map over here shows you the risk of dying before you have turned 75. And the light color indicates that there is a low risk, whereas the dark red color shows where there is a high risk. And if we take a look at the areas of the big cities, Aarhus, where I come from, and Copenhagen, we can see that there is a quite low risk of dying before you have turned 75. Whereas if you live in the rural areas, especially the southern part of Denmark, there is a really high risk that you would die early. On the right side here, I got a graph showing the life expectancy for men, and the red line here represents men with a high income, whereas the light red color line here represents men with a low income. And you can see that there is a clear difference between these curves. You can see through the last 30 years, the life expectancy has improved for both groups, but it's also clear to see that the life expectancy has improved much more in the groups with the high income. So I've heard you also face some problems with some serious problems with health inequity in Scotland. So I could expect that you will observe some of the same problems that we do here in Denmark. Yes, let's move on and talk about the department where I come from, Department of Clinical Epidemiology. Our department covers different research areas. So we have different groups at our department. We got a group conducting cardiovascular research. We got a group conducting orthopedic research, a group conducting diabetes research, and of course, most importantly, we got a group conducting kidney research. And the daily leader of this group is Christian Fynbo Christiansen, who is also my main supervisor. So at our department, we are more than 80 full-time employees. The majority of these employees are either medical doctors or statisticians. So I think the composition of employees at our department is a bit different from your department here. Yeah, and then we are more than 20 PhD students at the department. Let's dig into the type of research that we conduct and which type of data we use. So in Denmark, we have a lot of registries available for research. We are able to link all these registries through the CPR number system. The CPR number is given to all Danish residents upon birth or immigration. So yeah, the number enables the linkage of these registries, and the list of registries are very, very long. And most of these registries are nationwide. Here are just included some of the registries that we use most often. So we have a civil registration system which contains information about birth and death and the location of residency and sex. Then we got a patient registry which contains information about surgeries conducted at hospitals and diagnosis given at hospitals. Then we got a prescription registry containing information about prescriptions redeemed at community pharmacies. Lastly, we got a laboratory registry, which contains information about blood samples and urine samples, etc., taken both at the hospitals and in general practice. And we use the laboratory database to ascertain events of kidney disease in our projects. And here I have included a list of both pros and cons when you conduct the general cons and pros when you conduct research in Denmark. So we generally have a large cohort size when we conduct our research, because it's based on the whole Danish population, and we also tend to have a long follow-up on these patients, and this promotes high statistical precision and makes it possible to study rare events and rare exposures. Yeah, another pro is that our data is population-based, which reduces the risk of selection problem in our research. Also important to note that the data collection is independently of the research projects. We don't have to contact the patients to get the information about the diagnosis given and the surgery performed. But there are also some cons, definitely. So there are a lot of clinical variables that we can't access, and therefore when we conduct studies, there's a high risk that residual confounding may impact the association we investigate. So, for example, we have no information about smoking or alcohol or BMI, and also can also be very hard to determine the severity of the disease. And when you conduct a study, you also have to be aware of the validity of the codes that you are using. Some of these codes have quite low validity, and the completeness is also pretty low for some of the diagnoses that we use. Let's move on and talk about some examples from my own research. I hope this will give you a sense of the opportunities with our data. And both of the studies I'm conducting together with Simon. And the first study is entitled "The Prognostic Impact of Rapid Changes in Serum Creatinine After Surgery According to Pre-Operative Estimated Glomerular Filtration Rate." And I'm aware that some of you don't have a medical background, so I will try to give a short crash course in kidney physiology. So the kidney got numerous roles. One of the most important roles is to clean the blood. This primarily happens through the glomeruli, and I have depicted a glomerulus here. So here you can see that the glomerulus consists of a vessel network. The vessel network is surrounded by a capsule, and this capsule acts as a strainer. So the waste products in the blood are filtered through this capsule into the urine, and then the cleansed blood goes back to the system. The glomerular filtration rate, abbreviated GFR, gives a measure of how much blood that is cleansed per minute. And it is actually possible to measure this GFR directly, but it is a cumbersome method to use because it requires a tracer, often a radioactive tracer that you have to inject the patient, and then you have to take blood sample or urine sample sequentially, and based on that you can calculate the glomerular filtration level. But it is cumbersome to conduct. Luckily, we also got some biomarkers in our bodies. And the most important biomarker here is serum creatinine. Creatinine is a waste product from the muscles that are produced at an almost constant rate and is excreted almost solely through the glomeruli in the kidneys. So this means that the concentration of creatinine is dependent on the kidney function. So there exists an inverse relationship between the GFR and the concentration of creatinine, and you can use the creatinine level to estimate the GFR. That's also what we call eGFR. And in a stable phase, the baseline, the eGFR will give you an idea of the baseline kidney function in the patient, and you can use the eGFR to ascertain whether the patient got chronic kidney disease. You can also use the creatinine to ascertain whether the patient has an event of acute kidney injury. Acute kidney injury is characterized by a sudden decrease in kidney function. And you can define AKI based on creatinine using the KDIGO criteria. And KDIGO criteria is AKI as any of the following: either an increase in creatinine, an absolute increase in creatinine of at least 0.3 milligram per deciliter within 48 hours, or a relative increase in creatinine of at least 1.5 times baseline, which is known or presumed to have occurred within these 7 days. However, there is a problem because the kidney doctors aren't really happy with the first criterion in the KDIGO criteria. And the reason why is that they are concerned that patients with chronic kidney disease will be more likely to experience an absolute increase of 0.3 milligram per deciliter within 48 hours than a patient with a normal kidney function. And they're therefore concerned that an event of AKI will be less severe in patients with chronic kidney disease than in patients with a normal kidney function. We'll also try to illustrate this with this figure. So here we got two patients, one patient with a high GFR, in other words, a patient with a good kidney function, and up here we got a patient with a low GFR, in other words, a patient with a reduced kidney function. And the person with a reduced kidney function will have a higher baseline creatinine level because there is this inverse relationship between creatinine and GFR. So they will tend to have a bigger variation in their creatinine level, and therefore it is likely that they will be more prone to develop an absolute increase of 0.3 milligram per deciliter within 48 hours. So therefore, we chose to conduct this study to examine the impact of absolute and relative creatinine increases on the mortality across baseline eGFR values. We have designed this study as a cohort study, and we have restricted to patients undergoing major elective surgery. And the reason why we have done that is that these patients often have a measurement of EGFR before the surgery and also often have multiple measurements after the surgery. The information on the surgery was retrieved from the Danish patient registry. And we also retrieved information about the baseline EGFR level, and we defined the baseline EGFR level as based on the most recent creatinine value before the surgery, and this information was retrieved from the laboratory registry. Then we ascertained the changes in creatinine in the first 7 days after the surgery, and we ascertained both the highest absolute increase and the highest relative increase. The outcome of interest in this study was the 90-day mortality. And we used a logistic regression analysis to predict the mortality based on both the baseline EGFR value and the creatinine increase, and standardized according to the sex and age distribution and distribution of surgery types in the Danish population. And then we replicated, we are replicating the study in both Grampian and Taysart in Scotland and in Alberta in Canada. And here I got some initial results based on the Danish data. So on the x-axis, we got the baseline EGFR level, and on the y-axis, we got the changes in the absolute changes in creatinine. And the text and the color represents the mortality. So green represents a low mortality, whereas red represents a high mortality. And on this figure, you can see that when you compare it to a patient with a baseline EGFR of 90, then patient with a low EGFR got a higher mortality. And we can also see that patients with an extremely high baseline EGFR actually also got a slightly higher mortality. Then if we examine the mortality in patients experiencing an absolute increase in creatinine of 0.3 milligram per deciliter, we can see that this increase is actually associated with an increase in mortality across the baseline EGFR values. So it seems like that patients with a low EGFR value still experience an increased mortality if they experience an absolute increase of 0.3 milligram per deciliter. But it is also important to note that the relative increase in mortality is lower among the patients with a low EGFR because they have a higher baseline mortality than if you compare it to patients with a normal kidney function. So that's the initial results. The next step is that we are replicating the study in both Canada and Scotland, and it's an ongoing process. So both Simon and the researchers in Canada have run the code. And in this process, we have encountered some challenges. And I think some of the challenges that we encountered are some general problems that you encounter when you do a replication study. So when you do a replication study, it's very important that you give some concise instruction about how the data management should be conducted. Otherwise, you will end up having different patient groups with different data available. Then if you or when you encounter some errors in your script, when you're running the script, it can be very hard to determine what the error is, because typically you get a message from another sender reporting that they have encountered an error in their data set, and then you have to figure out how come they have encountered this problem, and you have to do that without having access to the data. So it can almost be like solving a puzzle with a blindfold, and be a very cumbersome job. Then you also have to be aware that you may see some different results in the different centers, and these differences can both be due to errors in your code or in your instructions, but it can also reflect the reality. And if it reflects the reality, you also have to consider whether you can pool the data afterwards. It could be the case that if the results are too different, it wouldn't make any sense to pool the data. Yeah. So that's the first example of a project where we have used the Danish data. Let's move on to another example, and this study is entitled New Glucose Lowering Drugs and the Risk of Kidney Outcomes in Cancer Patients. And let's start with some background information. So randomized control trials have shown that promising kidney protective effects of the new glucose lowering agents, SGLT2 inhibitors and GLP-1 receptor agonists. We know that these patients with active cancer or recent cancer have been excluded from these randomized control trials. We also know that cancer patients have an increased risk of developing both acute and chronic kidney impairment. So it may well be that these new drugs can ameliorate some of the problems that cancer patients are facing concerning kidney impairment. On the other hand, we also know that cancer patients generally have a poor survival when compared with the general population, and this may hinder a positive effect of these drugs. Therefore, we chose to conduct this study to examine the risk of acute kidney injury and chronic kidney disease progression and mortality in cancer patients with diabetes and receiving SGLT2 inhibitors and GLP-1 analogs. Yeah. So the plan is to design this study as a cohort study. We will include cancer patients with diabetes. Exposure will be within prescriptions of SGLT2 inhibitors and GLP-1 analogs. And the outcome of interest is, as I just talked about, acute kidney injury, chronic kidney disease progression, and death. And we are still in the designing phase of this project, and we haven't decided yet in which period we wanted to ascertain the exposure. One approach could be to ascertain the exposure before the cancer diagnosis. This corresponds to what we call a prevalent user design. The prevalent user design got some advantages, but it also got some disadvantages. One of the disadvantages is that you risk inducing selection bias, because you require that the patients have survived the time from the initiation of the drug to the cancer diagnosis. And it may especially be a problem if you expect that there will be some immediate reaction after you have initiated the drug. And it will also be a problem if you expect that a lot of these patients will discontinue the drugs early, because then you end up with a very selected cohort of patients. Another solution could be to use a new user design. And there are some different approaches when you have to do a new user design. One approach could be to conduct an emulated target trial. I don't know how many of you have heard about emulated target trial, but in emulated target trials, you try to replicate a randomized trial. So you have to set up the inclusion criteria and exclusion criteria as if you were to design a randomized trial. So when you conduct a new user design, you will typically restrict to patients who already have a cancer diagnosis, and you will follow the patient from the first prescription of the drug. The advantage of using this design is that you will mitigate the selection problem, but the design also has some disadvantages. In this example with SGLT2 inhibitor users and GLP-1 analog users in cancer patients, there is a potential source of bias. It's confounding because these drugs are typically prescribed for preventive purposes. So if a patient with cancer got a new prescription and initiates these drugs, it is probably a good sign. And this could potentially induce confounding by the cancer severity. Yeah. So it's like that we will encounter bias in either designs, and we haven't fully decided which approach we should go with, but we will probably end up choosing one of these and then conduct some sensitivity analysis where we try to elucidate the problems from different perspectives.